My name is David Beard, and I'd like to acknowledge my co-authors Marion Campbell, Jane Blaisby, Charles Vire, Sean Cousins, Natalie Blenko, Kate Gillies, and Jonathan Cook. And I'm going to talk to you about the use of placebo controls in the evaluation of surgical procedures, or the ASPIRE guidelines. I'd also like to thank the rest of the working party that joined us at St Anne's College back in 2018 to discuss these issues. Now, there are challenges to surgical evaluation, sometimes no different to other aspects of medicine. We want to know whether the surgery or the treatment is beneficial. We want to know how well it works, by what mechanism, and is something better? Should we be offering something else to patients to get them improved? But surgery does offer some unique aspects and some challenges as well, and they can be encompassed. I call them the 4 E's there. The expertise side of it, skill-based surgery, brings in some issues. Also the experience of the practitioner, the surgeon, issues of equipoise and offering treatment, and that also brings in elements of ethics as well, and particularly in an area of placebo control, which we're going to talk about. All those aspects are quite key. Now, we should look at the whole purpose of evaluation and what we're trying to do, and that is to find out whether something works or not. So it's a question of fundamental efficacy, or efficacy, whichever one we want to say it. We can do that in a couple of ways. One is by comparing against not doing anything at all, no intervention. We probably should have done that right from the outset with surgical interventions. But you can also control for the placebo effect, which is quite strong in surgery, as we know. And that has advantages because it gives us an account of the assay sensitivity and whether either treatment actually works or not. And it also can separate the true effect out, which is very useful as well. And that's been well expounded by Temple and Ellenberg. Another alternative is to compare the efficacy of 2 different treatments, a hierarchy of benefit, which is a different model entirely. Now, if you are going to do a placebo control, obviously you need the treatment intervention, which we're investigating, and then the placebo control, which is a clear-cut design. And some people think that that's adequate. In many cases it is, it depends on your position, but you can add in a natural history arm to that, which will give you an overall view whether the surgery, regardless of whether there's a placebo effect or not, is valuable. And the placebo side of it gives you more of an understanding about the mechanistic and interpretation side of things. So natural history can be added to a placebo control as well, making it a 3-arm study. We did that in Seesaw with a study looking at subacromial decompression, a surgical procedure for subacromial pain. And you can see here the 3 treatment arms. The red one is arthroscopy only, the placebo intervention. The blue is the actual decompression, the surgery that we were looking at. And then the green line is no treatment, or the natural history. And you can see there's no difference between the arthroscopy and the decompression, the placebo and the actual intervention. But more interestingly, perhaps, is that if you did nothing at all, there was also some benefit. And we wouldn't have been able to see that had we not had a natural history arm. Lots of potential issues I've already said. Let's just skip through a few of them in terms of design and identifying the critical surgical element, ethics, conduct, and statistics. First of all, this critical surgical element. So this is about taking out the component which we think is the thing that causes the benefit or provides the benefit. And we've come away from calling it just a placebo intervention, and we now want to define it in more higher level of granularity in terms of fidelity to the actual treatment. So here's just a schema for you. The fidelity level on the left-hand side there, the index procedure, obviously not a placebo, it's the complete surgical intervention. The bottom side there, you've got minimal fidelity, where you do very little indeed. It might be just skin incisions or close to sham, or sham as you can get, although sham is a bad word for patients, remember. And then something in the middle, and then going to higher fidelity, where you've got nearly the complete treatment with just the active ingredient removed. And an analogy for that is something like the car. You've got a full car there, you've got the car with the engine removed, further bits removed, until you have something which looks like a car but isn't a car, and vice versa, different bites out of an apple till you get a pretend apple. That might seem straightforward, but it's not, and our colleagues in Bristol have been busy at work trying to unpick that, and they've produced the DITTO guidelines, whereby we deconstruct the surgical intervention and identify components of it, which is really important. Once the element which we think is causing the benefit can be separated and identified, that is a critical stage in stage 2. Take that away, and then just think about the risk and the feasibility of doing that to make sure that the investigation is safe. And then finally, just optimize the placebo side of things with masking to make the experiment work even better. Moving on to ethics. we need to consider whether we harm patients or not. And again, Charles Vye has been very important in this area for us. Some people do think that it's unethical to expose patients to risk without prospect of benefit or medical value and intervention. A reasonable position to take, but one could say that all research involves non-therapeutic procedures which are done for scientific ends, and where do we stop with that? But we do need to make sure that the benefits and harms are in reasonable relation, they're balanced, and that is looked at very carefully in a placebo-controlled study, and that feeds into the informed consent, as you'll see in the next one. But it should be minimal risk, and we've shown that there is minimal risk with a paper back in the BMJ with Karolina Vortaleska. The second aspect of ethics is the consent and patient information, which I think we haven't done particularly well in the past before, and I'll put my hand up to that as well, but getting better all the time, and Katie Gillies has helped us out with this one. So we do need a full description of the placebo surgical procedure, and it has to acknowledge that there is no known mechanism by which it could work, and that has to be in that that consent process, and the recognition that it's being done for research purposes. Sometimes that's missed out and could be disingenuous. And then the language is important in there as well, so you need to make sure that there is no unwitting therapeutic misconception which is conveyed to the patient. But quite a skill to get the consent and patient information correct without disadvantaging the trial. The conduct side of things is got many aspects as well. We can't cover them all today, but equipoise is a big one. Circles back to the ethics. This is about risk without having any benefit, and very difficult for surgeons who are strong decision makers to be in a position where they are uncomfortable. It's an uncomfortable place to be, where they're suggesting that something that they may be offering isn't as valuable as it may have thought to be. But the uncertainty has to be big enough, it has to be substantial enough to make sure that both either the individual is happy enough to be involved in the trial, or the community as a whole is. And that can be helped with qualitative research with groups like the Quintet group, again in Bristol, who've been doing this for many years, to unpick that and make sure that if there are equipoise issues, they can be sorted. But I won't talk a lot about statistics interpretation. The main thing here is that you probably want to do a scenario check beforehand, an a priori look to see what you might expect from this study, and that will help you when the results come out to translate it into practice. There's no shocks, and if there's a hierarchy of benefit, we can convey that. But a couple of issues there. You just need to be thinking perhaps whether, if the placebo is beneficial, should we be classifying it as worthy treatment, and maybe we can discuss that later on. Now, all these issues and more are covered off in our Lancet paper, including the Aspire checklist and some of the corollary papers and supporting papers that we've produced. So just to conclude, placebo control is a complex type of comparison group and powerful, but it can present some challenges in a surgical setting. In my opinion, it's a beautiful thing, but very hard to control, a bit like some of those items there. George Best, a Mustang, Porsche 911 if you've ever driven one, and some would even say the Scottish nation. Thank you very much indeed.